Hello and welcome to Two Peds in a Podcast, an educational podcast from Derbyshire Children's Hospital. My name's Dr Sarah Simons and I'm an F2 in the East Midlands, and I'm joined today by Dr Ian Lewins, one of the consultants from Derbyshire Children's Hospital.
Hello, good morning.
Today we're going to talk about observing, so not an active intervention but a really important tool in paediatrics. Absolutely. And in the assessment of a child, which is a little bit different, I think, for doctors who've maybe only worked with adults before. And I think sort of sitting back and keeping an eye on a kid who has shown up to A&E is something that perhaps you wouldn't do with an unwell adult who'd shown up to A&E. Yeah. You'd tend to get a bit more hands-on sooner rather than later. But I think that's an important distinction to recognise and understand why we do that sometimes with paediatric patients.
Absolutely.
So to begin with, what do you mean when you say we're going to just keep an eye on this child for a while?
Okay. So I think you're absolutely right, and I think it's one of the things that we try and get across to people is when they often come to paediatrics, you say, well, kids get poorly very quickly, but they also get better very quickly as well. And one of the things that particularly if we've got trainees who have worked off both sides, are working maybe in adult ED as well as peds ED, is that they're very keen to do lots of investigations, lots of blood tests very early. And actually, I think it's important to emphasise that observation is an investigation in paediatrics, and that's something that takes a bit of while to get used to. Actually, simply observing and seeing what this child like actually may give you far more useful information than a CRP, which then comes back at 50, and you think, I have no idea what to do with that. To which answer is, well, don't do it in the first place. But observing is really important, and to try and help. And one of the things that people often struggle with when they come to paediatrics is, well, I've got a rough idea, a reasonable idea of what normal values are for adults. I know what's tachycardic, I know what's bradycardic, but pesky children have different ranges and different numbers, and how on earth am I supposed to remember all these things? To which answer is, you don't have to.
Okay.
We try and put something in place, and that's where we use this thing called the POPS score.
Okay, so the POPS score, so unlike the early warning score and early warning signs that you have for adult medicine, how does the POPS score differ?
So the POPS score is something that we use specifically in ED. It was originated from Ffion, Davies and Damian, Roland in Leicester, and we've adopted it here, and it's been increasingly adopted globally, in fact. And it gives you an idea of wellness, if you like, in very much the same way that a Pew's score or a new score, or it's in that sort of same idea. But it's useful, and the way we score it is differentiated by age. So unlike a set for an adult, there's a set numbers. Actually, we break it down by age because we recognise that different children have different parameters.
Yeah.
So the way that the one that we use is broken down is 0 to 1, 1 to 2, 2 to 5, and 5 to 12. And then once they're beyond sort of 12, 13, then you're kind of looking at probably adult numbers. Yeah. And we break it down into different things. So we look at pulse, we look at respiratory rate, and we look at temperature. So basic numbers, and the scoring system goes from 0, so green, if you like, to score 0, so a normal range for heart rate, a normal range for respiratory rate, and a normal range for temperature. And then you can score 1 or 2 as your maximum, either way. So if you're mildly tachycardic, you'll get a 1. If your heart rate is slightly lower than it should be, you'll get a 1. And equally, if you're very tachycardic or bradycardic, you'll get a 2. So the first thing is very simple things: numbers, pulse, respiratory rate, and temperature, and we do those for all the age groups that we've talked about. But we've then got different things that we include SATs. So SATs, you score a SATs out of either 0, 1 or 2. We look at an AVPU, so we don't necessarily do a formal GCS. We'd look at an AVPU. So are you alert?
Yep. That
gets you a 0. Are you responsive to voice? That gets you 1. Or are you responsive to pain or unresponsive? Gets you a 2. So that's thinking. So we're going down the A, B, C, D. This is your D bit. Breathing, again, is something that we look at. So we're thinking about if there's no distress at all, you get a 0. If you've got mild recession, you'd get a 1. If you've got severe recession, you get a 2. But then we also recognise that in paediatrics there are other noises that we should be worried about. So if they are grunting or wheezing, you get a 1.
Yeah.
And if you've got stridor, as we talked about in other podcasts, you would automatically get a 2 for that. And the other categories that we've got that are different to adults is we've got our high risk groups. So children who are on long-term steroids or are diabetic, we recognise them as a high risk group. You get a 1. Equally, if you're an ex-prem or you've got a sort of syndromic condition, you'd also get a score of 1. And those children who are very high risk are your congenital heart disease children or your oncology patients. They get a 2.
Okay.
So some children will automatically walk through the door
And
with a high
ticks
POPs.
and boxes already.
Exactly.
Yeah.
The last category.
Yes. So the gut feeling category is quite an interesting one, because I think it sounds like objective measures are the basis of the POP score otherwise, whereas the gut feeling is obviously more subjective.
Absolutely.
And that's something that very much depends on, I suppose, your own clinical experience, your frame of reference.
Yeah.
And also I think taking into account parents' presentation and the reason that they've come to A&E, I think, which is quite interesting in itself.
And I think it's really important actually, because it's that thing that you can't quite quantify, and particularly when you've got fairly senior people triaging the nurse, and they'll come and say to you, look, the numbers look okay, but they don't smell right to me. There's something not quite right about this child. And I think giving that equal measure to all the other things, I think, is really important.
Yeah.
The number of times that I've been saved by somebody saying, I know they're okay, the numbers are okay, but I'm worried about this person. And I think that gives it some sort of a concrete, I am now giving this child, if you've got a low level of concern, you'd score 1, or if you've got a high level of concern, or to you as an experienced practitioner, this child looks unwell to me, you get a 2.
And I think in the context of knowing how quickly kids can, get better, but kids can deteriorate very quickly, I think that's an important thing to sort of stop at the door and say, I think someone should see this kid sooner rather than later.
Yeah. And so in the system that we use, when we're triaging them and putting them through electronically, and the nurses are filling those in, it will generate a POPs score for you. And one of the questions sort of people new to it says, well, what does it mean? Does it translate into something? Is it like a GCS where a score of below 8, you must do this? To which the answer is, well, it's just a score. And we tend to say, look, any child who's scoring 8 or more, you've got to think, should I be actually seeing this child in resus and taking them very, very seriously? But I think generally the way we tend to use it is to monitor this child, to say, look, this child came in with a POPs of 3. For example, maybe they're a bit wheezy.
Yeah.
We've done something about it. Or maybe they're a bit stridulous. We've done something about it. Now I think, having done those, in my clinical assessment, I think they're ready to go home. We try and do another repeat set of OBS within the hour before they go home, including a POP score. If that score's gone from 3 to 0 or 3 to 1, something like that, you can say, actually, that seems a sensible decision to let them go home. If they've got high POPs, and they've still got a high POPs, it's telling you they're not better. And you've got to think why. You've got to think, why are they not better? Or equally, if they've got a higher, if you're saying, I think this child's well to go home, they walked in with a POPs of 2, they've now got a POPs of 5, you've got to really question, should this child be going home? So it's something that we try and encourage all people to sort of use in the department as a tool of measuring wellness, if you like. And we, in our department, we've got all these printed out and laminated, so every computer has one of these attached to it. And what I would say to trainees is, look, don't try and remember these numbers. because you'll
It's very difficult.
It's difficult, and you'll make mistakes. I've been doing this a little while now, and I still refer to the POPs chart when I'm looking at this child to say, do I agree with this POPs score? And actually, I think they're relatively well. Am I right that they're relatively well? So that's how I would use it.
Yeah. I think one of the markers on the POP score is temperature.
Yeah.
And that's something that can sometimes be a little bit controversial, and sometimes you'll see parents who've come into A&E and said, well, he wasn't quite right, and I didn't want to give him any Calpol, didn't want to give him ibuprofen because I just didn't want to mask anything.
Yeah.
And I think as junior doctors, often those tend to be the kids who maybe aren't very unwell. Perhaps they might be a little bit hot, they might be a little bit cranky, but they're not very unwell, but perhaps they would be scoring quite highly for perhaps being a bit upset, a bit distressed with a high heart rate and a fever, which could well give them a POP score of about 4, which is not insignificant.
No.
And I know that we're going to talk about child with a fever at a later date on another podcast, but what would your take-home messages be in terms of assessing a child with a fever and advising on medication and things and antipyretics?
And I think there's lots of things to talk about in terms of fever and antipyretics and whether you should or you shouldn't. And one of the, I think when we're looking at POPs and fever and thinking about sepsis is this concept of an inappropriate tachycardia. And we know that being poorly makes you tachycardic, generally. We know that being hot makes you tachycardic. So trying to work out who's a bit poorly and hot, but not ill, versus the person who is hot and ill. And so we have this concept of inappropriate tachycardia, which works along the lines of, look, for every degree above 37 that this child is, you can almost correct the heart rate. So for every degree, you take 10 off the heart rate. So if your child's got a temperature of 40, that's 3 degrees above 37. We would take off 30 off the heart rate.
Yeah.
Now, if you've done that, and that puts that heart rate in the green 0 POPs category, then they're probably just hot and tachycardic. If when you've corrected that, taken that 30 beats per minute off, they're not in the green, they're either in the amber POPs of 1 or red POPs of 2, then that's telling you it's not just the fever that's causing the tachycardia. They are inappropriately tachycardic, and they're probably trying to tell you, I'm ill as well as hot. And that's where having that POP score, having that reference is really vital and really essential.
Yeah. Okay. Sounds like, obviously, with all patients, it's a case-by-case basis, but the POP score is a really good way of, across the board, saying, look, I'm worried about this child because of X, Y, Z, whether it be their numbers or whether it be your gut feeling. And ultimately, it gives you a tool to say, I think we should escalate, or I think we should maybe just keep an eye for a little bit longer, which is always worth thinking about.
Absolutely.
Across any clinical context, really. Yeah,
and it's used in very similar ways to other early warning scores. Is high scores escalate early to seniors, get them to come and see them. They might share your concerns, they might not, but if they don't, always get them to say, I was worried, you don't seem to be worried. Why is that? And get them to explain to you, and that's how you learn.
Fair enough. And I think on that note, I think that's about it really for POP scores. Thanks very much.
Thank you.
I nearly said points mean prizes.